Moving on to my last topic for the day, bone health in patients with multiple myeloma. We know that patients with myeloma have their bones affected in 70% of the cases. The reason behind that is that plasma cells that are affected in myeloma make certain chemicals that can dissolve the bone and prevent new bone formation. Hence, it's not uncommon to see patients with myeloma actually present with bone loss, bone pain, bone fractures. These fractures oftentimes can happen in the spine and hip area, which leads to compression fractures and significant pain and debility. We will be discussing today the management of compression fractures with procedures like kypho and vertebroplasty, as well as bone modifying therapy to help with bone pain, bone loss, and prevent bone fractures with zoledronic acid and denosumab. Let's talk about vertebral augmentation. So patients with myeloma who present with compression fractures in the spine or the pelvis area can have significant pain and debility from these complications. One way to actually address this complication of myeloma is either a vertebroplasty or a kyphoplasty. Both of these are procedures where we can inject cement in the compressed and fractured bone, solidify the bone, and at the same time inject some numbing medication that can actually anesthetize the nerves in that area around the bone. These procedures can be very helpful in a majority of patients and can provide instant relief to the patient as they undergo the procedure. The choice of the procedure primarily depends on the expertise that are available and the cost of the procedure and patient preference. Moving on to the bone modifying therapy, there are two different medications that are available for patients who have bone involved at the time of their diagnosis. One is zoledronic acid and another is denosumab. We usually recommend that patients receive zoledronic acid or zoledronate intravenously at 4 milligram dose at least once every month for the first year of their treatment. After 1 year, if they have had a good response to the chemotherapy, the zoledronic acid can be given every 3 months for additional 12 months and discontinued after. Anytime patients have myeloma disease relapse, they should actually resume the zoledronic acid as well. Denosumab is another option available as an anti-resorptive agent. It's usually given as an injection in the muscle, is given at a dose of 120 milligram once every month for the first year and can be given every 3 months for patients who achieve a deep remission after 1 year. One important point to remember is that if you are on denosumab and you are discontinuing therapy because you have achieved good response to treatment, please get one single dose of zoledronic acid to prevent any rebound effect and bone loss and bone fracture as you stop your bone modifying therapy. Bone modifying therapies with Zometa and denosumab can reduce bone pain, can help with hypercalcemia, can prevent bone fractures, but at the same time, they can cause certain side effects, including low calcium levels. They can cause damage to the kidneys and also cause more side effects if patients don't have normal kidney function. And in certain rare instances, you can also see a condition known as osteonecrosis of jaw, where there is significant loss of the bone around the teeth in the jaw if there is a dental extraction performed. Hence, any patients who are receiving bone modifying therapy with Zometa or denosumab should actually be on daily calcium and vitamin D supplements. We should avoid the use of these medications in patients who have renal failure. For patients who have compromised renal function, we should dose adjust these medications. Before starting any patients on bone modifying therapy, it's important to undergo a routine dental assessment, evaluation for any dental extraction, which should ideally be performed prior to starting these agents. Routine dental procedures like cleaning, crowning, root canal, they can be performed provided there is good gum health and an experienced oral surgeon who's able to perform these procedures. Anytime a patient has received Zometa or denosumab in the past and they need a dental extraction performed, it's important to give them a holiday from these agents for at least 3 months before and at least 6 to 12 weeks after the procedure. I hope you enjoyed my presentation and all of the supportive care management that is pivotal to the care and management of our patients in multiple myeloma. Thank you.